So once you open the OVC kit, everything's contained within the kit. You can see here we've got the new version of the OVC band by Rhondium, a fantastic design that's going to make life easier to place the band over the tooth. We have the 2 stretch wedges, we have the replica, and we have the subgingival wedges. So everything's in the kit. And just make sure that when your dental assistant opens a kit, that she doesn't throw the lid away, because that's where the OVC is located. You can see it's there in the enclosed casing of the lid. We bring the selector key, and you have to make sure that the selector key corresponds to the lower molar. So you can see the LM on the selector key. So using the selector key, we need to choose the size of the OVC. So the tooth has been already prepared. We're restoring the tooth 4-6. So we measure out, using the selector key, we actually measure the mesiodistal space, and in order to determine which size OVC we're going to choose. So in this case, you can see we've chosen the L, which stands for large. So we ask the assistant to get the large lower molar 4-6 or 4-7 OVC. In clinical circumstances, sometimes it's difficult to place the selector key because of the cheek or the tongue getting in the way. You're able to bend the selector key to allow better access intraorally, as demonstrated on this model. So here we've chosen the size of the OVC. Now within the kit, we've got the replica. So the replica is a copy of the hard part of the OVC. So here you can see now with the tweezers, we bring the replica and we place it over the tooth preparation. We ensure that the replica sits comfortably over the occlusal surface. Normally in the mouth, we ask the patient to occlude onto the replica, and the replica should not distort or shouldn't be compressed. So we want to make sure the replica should move. You don't have to pull it out, but the replica should be a little bit loose fitting to ensure that you've got adequate tooth reduction. Some dentists may choose to use a material called occlude, and that's a spray that you can spray to the undersurface of the replica. And what it does, it leaves a mark on the tooth to tell you if you have any high spots that you need to do further tooth reduction. Now, also the use of the replica, it serves another purpose, is that it tells me how much of the tooth preparation, not only how much of the tooth preparation we need to prepare, but also because it's a copy of the actual hard shell, I actually visualize where the eventual OVC should sit in relation to the adjacent marginal ridges, which is important because once you've got the replica in place and the patient occludes onto the replica, if it doesn't distort, that probably should be the ideal seat of the OVC. So using the replica gives us a guide of the actual final seating of the true OVC. Okay, so once we've done the tooth preparation, the next stage is we take the band out of the kit, we place the band over the tooth preparation, and what we're aiming to achieve is that the flared part of the band, which is the top of the band, should sit at the same level as the marginal ridges of the adjacent teeth. Now make sure that the band doesn't sink below the adjacent marginal ridges. You have to ensure that the band sits a little bit above the marginal ridges, okay, but at the level is perfect, because if it sits below the contact or below the adjacent teeth, there's a risk that the OVC, when you place the OVC, it may collapse the band internally. So just ensure that the band sits at the same level as the adjacent marginal ridge. And you can see when we turn the model sideways, you can see that the band sits beautifully just above the adjacent marginal ridges. So here we use the hex stick to tighten the band. And now you can see that there is no space between the band and the tooth, which is perfect. So we've got a beautiful tight seal of the band over the tooth preparation. A great innovation since the previous version, and I'm sure it's a very unique band. So here you can see sideways, the band sits beautifully with the adjacent marginal ridges. And really, essentially now we're ready to do the next procedure of direct bonding. So the aim of a proper seating of the band is that we don't really want to see any spaces between the tooth and the band at all. So if a gap appears between the tooth and the band, particularly in deep interproximal areas, it's important to wedge the band against the tooth. Once the band's in place, you've tightened it, the band sits well, we just carry out our normal bonding techniques. You apply etch, bond as per normal as you do at any direct restoration. If you have a situation where you have a deep proximal box, sometimes what may happen as you tighten the band, you may find a space appears between the band and the adjacent tooth. If that occurs and you have a deep proximal box, the idea is that we place a very small amount of flowable resin in that area, and we mustn't have the flowable resin go into the contact area. It's got to be below the contact area for fear that we can't place the OVC. So we place a very small amount in the proximal box, and then using an instrument, we hold that band against the adjacent tooth and we cure it at the same time. So that ensures that the band flares out and meets the adjacent tooth, and it reduces the likelihood of having that space. The other reason why we need to build up the proximal box is that when we have a deep cavity, we find that if you place the stretch wedge and you start pulling on the stretch wedge, you may find that the stretch wedge may distort the band. It actually may pull the band within the tooth cavity and leave a possible an open contact. So it's important that we do this initial step of placing a very thin layer or a small layer of the flowable resin in the proximal box to ensure a tighter contact. And it's the flowable resin is held with an instrument, a plastic or a burnisher, and then that area is light cured. And if you have both surfaces, if both the mesial and distal surfaces require this technique, you need to do one side at a time. So before we place the stretch wedge, it's important to pre-stretch the wedge. So you can see here we've stretched it a couple of times and to activate the stretch wedge. And we've found that by doing this technique that you actually get better tooth separation by pre-stretching the wedge. You can see that once it's pre-stretched, it appears longer than the original stretch wedge. So it's important. If you don't do this step, and you some instances you may stretch the stretch wedge, it may break. So it's an important step that you need to pre-stretch the stretch wedge. When you're inserting the stretch wedge, if the band is tight up against the adjacent marginal ridge, sometimes you need to just move the flange of the band out. Be careful not to tear the stretch wedge on the sharp edge of the band. We place the stretch wedge in place, and as we pull, the pulling action is a steady but strong pull. So we may have to do that slowly in order to get better tooth separation, to allow the periodontal ligament time to affect the separation between the band and the adjacent tooth. So it's a steady and strong pull. And occasionally, because of access, if I can't get my fingers in place, occasionally I use a pair of hemostats and I grab it from the buccal, and using my other finger, I push on the lingual, but I do it gradually. So it's a steady, gradual, but a very strong pull. And just aim to get as much pull as possible in order to get the best separation to compensate for the thickness of the band. You might find that the band may be distorted or may pull in. Just make sure that before we restore the cavity that we do a very light burnish on the internal part of the band. As you can see here, we're using a burnisher. We're actually doing a very light burnish just to make sure that we readapt the band to touch the adjacent tooth. The reason why we say light burnish, because we don't really want to create any indentations on the internal surface of the band, because obviously that will be picked up with the composite, the flowable composite, or the OVC soft material. And then we're ready to place a flowable composite. The flowable composite is uncured. So the reason why we use a flowable composite is we want to make sure there's no air entrapment between the OVC and the tooth surface. So you place a very thin layer of flowable composite, we don't cure it, and then we seat the OVC on top of the uncured material. Now we're ready for the OVC to be placed. So the OVC is located in the lid of the packet. So remove the OVC. And when you remove the OVC, occasionally the hard and soft layer may separate. So just using your fingers, just press the soft material back against the OVC in case it separates, but also aim to achieve a conical base of the soft material or a dome shape rounding the base of the soft material, and that it reduces the likelihood that you can get air entrapment. We place the OVC into the band. So once we've got the OVC in place, the next stage is I use my thumb, or you can use a burnisher to press it down in order to seat. What we aim for is that we get the OVC to seat very similar to what we recognise with our replica. So look at the marginal ridges to make sure that the marginal ridges are identical to the adjacent tooth, and using the plastic, you can hold the plastic and overlap the adjacent marginal ridge and check that. In some instances, you may get the patient to close. So if you don't have rubber dam on, you can get the patient to close down on the OVC in order to make sure that the occlusion is correct. Problem is, in some instances, a patient may have a plunger cusp that you haven't earlier identified with a replica. And if they do have a plunger cusp, they may shift the OVC. It may be shifted buccolingually, or it may be rotated if they're biting down. But if it's possible, then it just aids in reducing the time spent having to adjust the occlusion if you can get the patient to close on the OVC. Ensure that the OVC marginal ridge is in line with the marginal ridges of the adjacent teeth. So removing some of the excess prior to any curing helps to identify the OVC and see the margin a bit better, as shown here using the plastic. And you may need a mouth mirror just to ensure that the heights of the bucco or lingual cusps are horizontal. And that's why it's important that we seat the band correctly, because we can also use the actual edges of the bands as a reference points to the buccal and lingual cusps. But we now bring the selector key to the tooth, and we're going to spot cure the center of the OVC. So we bring the selector key, and there's a little hole in the end. We place that over the middle of the occlusal surface, then spot cure for 3 seconds. So curing that area allows the OVC to be fully immobile. I would test it using an instrument. I would just bring that over the occlusal surface to see whether the tooth, the OVC moves. If it moves, then I think you need to do a couple of more seconds of curing. But generally speaking, after a 3-second cure, the OVC won't move, and now you've got time to remove the excess around the margins of the OVC with a band. So it gives you a great, there's no other better opportunity you don't have this opportunity when you're seating crowns to do such a procedure, but using the selector key and spot curing it allows the operator, it gives us so much time now to remove the excess, and you can do it at your leisure. I spend some time removing the excess in the mesial and distal areas, because the OVC the marginal ridge of the OVC is already prepared, and I don't want to spend too much time doing adjustments in this area. So sometimes I actually spend a little bit of time just clearing the softer material at the marginal ridge areas, mesial distally. Occasionally, if you have any flowable composite material that may ooze out, you can use maybe a triplex to blow some of the flowable material. But spend a bit of time just trying to remove some of the excess in the proximal areas, because really, once composite's cured, you obviously have to spend some time adjusting. So the more excess you can remove, it makes life easier later. So spend some time removing some of the excess. And you can see it's looking quite neat here. So once we've achieved that, we fully cure the surfaces. You may choose to cure, I would cure each cuss separately. We have a turbo setting on a curing light. We cure all the cuss. Now, to separate the band, we loosen the screw using the hex driver. And here you can see we place the plastic in the buckle area between the band and the tooth. We tweak it. Once we've created space, we can generally slide the band up. If you're having difficulties intraorally, sometimes you can actually bring a pair of scissors and cut the lingual area of the band. But generally speaking, it comes out fairly easily. So here we go, we've got now an OVC that's fully cured. We remove the stretch wedges. So the more time you spend removing the excess, I imagine that there's less time spent doing the adjustments. And once we turn the model, you can see there's very little excess material we need to remove. Okay, so once you remove the band, depending on how much excess there is, if you have a lot of excess, you may need to use a diamond burr. But most of the time you can remove a lot of the excess just by using the disc. So I go through all the discs, the coarse, medium, and fine to remove, because you really want to create a invisible margin and a seamless join, and go through the whole range of discs. And as you can see now with the finished product, how we've polished it, it looks magnificent. You can barely detect the join and your job's done. So how easy is that?